I detect a quorum with members Huffman, Bradford, Gadd, Nash, Vice Chair Prepty, and Weiner. Oh, and Councilmember Benton. We didn't have anybody sign up for public comment today. We're going to go ahead and talk about the consent agenda. My proposed consent agenda, colleagues, is item 1, 2, 3, and 5. So everything but item number, I'm sorry, and 6. So everything but item number 4. I'm going to read these. You'll still have a chance to remove something if you'd like. Starting with item number 1, RS 2026-1768, sponsors Toombs, Huffman, and Bradford, a resolution amending the pay plan adopted for general government employees effective July 1, 2025. Item number 2, RS 2026-1774, sponsors Toombs, Huffman, Welsh, Ewing, Stiles, Swara, and Gadd, a resolution approving an application for a Predators Foundation helper grant from the Nashville Predators Foundation to the Metropolitan Government, acting by and through the Office of Family Safety to fund the 3rd annual back-to-school fair for families impacted by interpersonal violence. Item number 3, RS 2026-1775, sponsors Toombs, Huffman, Welsh, Ewing, Stiles, Swara, and Gadd, a resolution accepting a grant from the Carolyn Smith Foundation in conjunction with the Community Foundation of Middle Tennessee to the Metropolitan Government, acting by and through the Office of Family Safety to provide funding for the holiday shop for victims of domestic violence and their children. Item number 5, BL 2026-1199, sponsors Toombs, Huffman, Welsh, and Benton, an ordinance to approve an affiliation agreement by and between Liberty University, LLC, Liberty, and the Metropolitan Government of Nashville and Davidson County by and through the Office of Family Safety to provide fieldwork experience for students enrolled in Liberty University social work programs. And item number 6, BL 2026-1205, sponsors Toombs, Huffman, and Ellis, an ordinance approving a master services agreement between the Metropolitan Government of Nashville and Davidson County, acting by and through the Metropolitan Nashville Police Department and Care.com, Inc., to provide a digital resource for eligible individuals to connect with a network of individual and corporate care providers and access online content. Do I have a motion? Second. All those in favor, aye. Any voting no. Any not voting. And welcome, Councilmember Evans. Consent agenda passes 8 in favor, 0 against, 0 not voting. Okay, moving to the only item not on consent, item number 4, BL 2025-1188, sponsors Evans, Siegel, and Huffman, an ordinance amending sections 12.08-050 and 12.08-060 of the Metropolitan Code of Laws to authorize qualified personnel of the Nashville Department of Transportation to direct traffic and to grant traffic direction authority to fire department personnel during emergency situations. Do I have a motion? Any discussion on this item? Vice Chair Prepty, you are recognized.
Thank you, Mr. Chair. I do believe that previously in the Transportation and Infrastructure Committee, this bill was deferred by rule, and I also know that there was one amendment. I don't recall how long it was deferred, but I do believe that it is deferred. That it was deferred in previous committees, so I believe that a motion to that effect would be appropriate at this time. And if I could get some guidance, I'd be more than happy to make that motion.
I'll reference council.
Councilmember, no amendment was filed on the present legislation. The Transportation and Infrastructure Committee at its most current meeting passed or recommended approval of this bill without amendment.
Thank you, Mr. Chair, and thank you for that guidance. I'll state this in regards to this bill. generally has my approval. I think this is something absolutely necessary for us to implement to allow for the safety of our NDOT folks and for directing traffic. Generally, in very supportive of this bill. Just want to make sure that the language is really narrowly tailored for what we need here in Nashville and Davidson County. But generally, by and large, in favor of this bill. But we'll be having substantive discussions on this with the lead sponsor as well as those contemplating amendments on this. But by and large, very supportive of this.
Thank you, Vice Chair Prep T. Councilmember Nash, you're recognized.
Thank you, Mr. Chairman. I can't imagine what would be too complicated about this. I've directed traffic in the past, and I'm not a rocket scientist. I think we can get some good people at NDOT, some good people at the fire department who can manage to direct traffic, and probably unknown to many of us, they end up having to do it often anyway at the moment. So I think we ought to be moving forward and authorizing it.
Thank you, Councilmember Nash. Any other discussion? Moving to a vote. All those in favor, aye. Any voting no? Any not voting? Okay, item passes 8 in favor, 0 against, 0 not voting. All right, that concludes our agenda. Before I invite up our guests, we do have a presentation. I do want to ensure that everyone saw the press release for the joint committee hearing that we're going to be doing next week, next Tuesday, 5 p.m. in the council chambers. We're going to come together with the Public Health and Safety Committee will be coming together with the Transportation and Infrastructure Committee to discuss communication issues from not only this last winter storm, but just overall. And the goal of this meeting will be to really ensure that we as a government are better prepared in the sense of communicating with our colleagues. So I encourage all of you to attend that meeting, come prepared with questions, and that's all for now on that. With that, I'll invite up Captain Anthony Brooks from the Metro Nashville Police Department and Michael Randolph from the Mental Health Co-op for a short presentation about their wonderful program that I can't say enough good things about. The Partners in Care program provides such a service for this city. For far too long, we have seen folks struggle with mental health issues in this city, and not all of the time does that necessitate a police officer responding. And being able to send a mental health professional out on site to get someone the help that they need has been a godsend. So with that, I'm going to turn it over to you guys. Make sure your mics work for me there.
Hello.
Check.
Ladies and gentlemen of council, thank you for inviting us to present today. We are incredibly honored. My name is Michael Randolph. I am the Director of Co-Response Services with Mental Health Cooperative, and I'm a licensed professional counselor. And I'm co-presenting with Captain Anthony Brooks over alternative policing strategies with Metro Nashville Police Department to talk about Partners in Care. I'm going to give a brief overview of the program in case you may be unaware or forgot, and then kind of our 2025 data wrap up, and then some really good success stories, and I'm going to throw it to my colleague here. So Partners in Care is a true partnership between the Metro government and Mental Health Cooperative, where we take master's level clinicians and embed them at the precinct level with patrol officers to answer mental health calls primarily. It operates 6 a.m. to midnight, Monday through Friday. 2024 was our first citywide year, with 2025 continuing that. We have counselors in all 9 precincts this year. Our counselors work 4 10-hour shifts out of the 5-day week. There's 2 full-time clinicians per precinct. We have 2 floating clinicians, one during the day, one during the night, to kind of fill some of those gaps. I have 4 supervisors there. Each supervisor is over 2 precincts, and we have a training coordinator. There are 3 main aspects of Partners in Care, and that is the training of first responders, of our officers, the response to calls, and follow-up. Our training coordinator puts on CIT trainings. Captain Brooks is going to talk more in detail about that. We have three main goals for Partners in Care, and that is to divert people from the criminal justice system into the healthcare system, to streamline care for individuals and families in crisis. So if a family has to call 911 in a mental health emergency, a clinician is right there. They walk that person, that family through that crisis until they get to where they need to go. We try to address a lot of the shortcomings of the current mental health system, specifically the crisis system, where it can be confusing and a high level of entry to get the help you need in the right time. And our third goal is safety. Safety for those in crisis, safety for their families, safety for the officers, and safety for the clinicians. We also have a follow-up team. We have 3 levels of follow-up. Everyone who is seen by Partners in Care gets a phone call a week later from one of our follow-up coordinators to offer resources and the coordination of care. If they are going through, if they meet the criteria for a full crisis assessment, and I'll talk more about that momentarily, they'll get 3 phone calls within the first 12 hours to make sure that that plan is working for them, plus the week later phone call. And then also we can do face-to-face, in-person follow-up. The counselor and the officers can go after as well. A big part of the program is data transparency, data quality, and data collection. So every 2 weeks, we have a big data drop between Mental Health Cooperative, the the Police Department, Emergency Communications to the Health Department, where they're very talented epidemiologists. They strip the health identifying information. They analyze our data, and they tell us how we're doing. We have monthly data quality meetings to monitor any changes in our data and to see where we need to improve. So for 2025, PIC went on 3,884 mental health calls. I think about 12,000 non-mental health calls, but 3,884 mental health calls. This is a slight increase from 2024 with a pretty similar staffing pattern. Out of those calls, we served 3,000 unique individuals. So 77% of the people we've seen in Partners in Care in 2025 had not been seen by the mental health crisis system before in Davidson County. The busiest precincts were Hermitage, North, and South, with the Southeast precinct opening and being staffed by clinicians as of December 1st. That data will change next year, so be looking for that. 77% of the individuals we served were housed in a home, apartment, or group home, but that's about opposite in Central Precinct, where about 75% of them were unhoused. Some dispositions, some outcomes from these calls. About 50% of the calls, we can resolve that crisis at the home. Around 70% are diverted from the emergency room, and 10% are taken directly from the home right to a psychiatric mental health facility or to our crisis treatment facility in Metro Center. To really streamline that process. Our arrest rate in 2024 was 4% with a 2.4 use of force. 59% of the calls that we went on required a full crisis assessment. So what does that mean? That means that individual was experiencing suicidal ideation or attempt, homicidal ideation or attempt, or psychosis, which is could be a person experiencing delusions or hallucinating, such as hearing voices. This is up 5% since the program started. So the acuity of the mental health crisis seems to be getting worse out there, with a higher percentage getting a full crisis assessment. The top 3 reasons for these crisis assessments, again, suicidal ideation, psychosis, and homicidal ideation. But people can have multiple of them, so if you need more specific data, we can provide it at a future time. But people can be suicidal and experiencing voices and things of that nature at the same time. A statistic we're really proud of is since the 4 years that the program's been going on, we've had 0 crisis counselors injured on any mental health calls. But beyond the data, I think there's a lot of stories to tell with people that we are helping. And data can tell overall picture to make sure that we're doing a great job. But I had a story a clinician told me this week about Bill, which is not his names are changed, but Bill was seen in 2024 2 to 3 times by this clinician. They developed a rapport, they knew each other. And the last time that clinician assessed that consumer, he was suicidal, and he sent photos to individuals and his family with a gun to his head threatening suicide. They were able to locate that individual that last year and get him help at a psychiatric mental health facility. He was unhoused. He was agitated, and he told the counselor and the officer in that interaction that he was going to kill himself one way or the other, and what they're doing wasn't going to matter. In 2025, that counselor went on an unrelated call, and somebody called her over, and sure enough, it was Bill. He recognized her on scene, and he came up and reported that this year he's gotten a car, a job, case manager, housing, and was doing significantly better, and told the counselor that the last not so great encounter with the counselor is what really attributed to his success, and they really thanked the counselor and the officers for their help at that time. Just last night, there was a situation in a group home where a man was bipolar, kind of in a manic episode, and he was threatening to hurt others and throwing things in the home. He was impulsive, very aggressive. The PIC team arrived. The officer made sure the scene was safe. We were able to de-escalate that scene and took that individual directly to get mental health care, and he was not arrested. And they were able to start that treatment for his bipolar disorder. This week, we've done some work with the Red Cross shelters, with people who are unhoused or in the warming shelters to help with some of the severe mental health issues there. And another thing that we've started in the last year is we do monthly recidivism meetings. So if there's individuals who are calling 911 or interacting with police often per month, we run a report, we look into those cases, and the follow-up team and our supervisors, we really try to form a plan of care where we can offer someone an alternative than having to call 911 for help. And you'd be surprised that often their phone is shut off and the only number that works from that phone is 911. And I'd like to hand it over to Captain Brooks.
Thanks, Michael. Thank you, Mr. Chairman, for having us and members of the council. As always, you guys have been so gracious to us with Partners in Care, and to me specifically with Office of Alternative Policing Strategies, not only with Partners in Care, with other programs that I oversee, for allowing us to come and speak and highlight the work that we're doing. So I wanted to state that again. Michael did a really good job of giving you a little bit overview of our program. He talked a lot about data. You heard him say the word data a lot. And that's because when we started this, that was the driving force behind how we wanted to help people. The main goal was to get the proper help to the proper people, but all our planning was data driven. It's like the great Sherlock Holmes said, in the words of Arthur Conan Doyle, data, data, data. We cannot make bricks without clay. So we did a lot of research on the front end to see where the highest volume of potential mental health crisis calls were occurring in our city, because we did not want to launch citywide at the beginning, which some people might think is counterintuitive, but we wanted to do it small scale and make sure we were doing it right. Many of you in this room know that we did a lot of research and identified the North Precinct and the Hermitage Precinct as the two areas of greatest need, and launched a one-year pilot program at those precincts on the day and evening shifts. And we did that so that we could measure the data for that year and we could correct mistakes we made. The first year wasn't all smooth sailing. We made a lot of adjustments so that as we expanded, we could do it correctly and do it in the most effective manner. DEC played a great role for us in the data collection and the planning phase and identifying those calls for service. And anytime I speak about Partners in Care, for fear of looking like I'm taking a lot of the credit myself, I always want to throw out the great work and foundation laid by my predecessor, Inspector David Imhoff. He was one of the architects of this program and helped with a lot of the data and research in order to build it from there. And from there, once we launched the pilot, we moved on to each of our precincts based on the area of greatest need. And you'll hear me say that because that'll come up later. But we eventually expanded in this order from central to south to midtown to Madison to east to west, and then became a citywide program at the time. Eventually this past year, we would of course add the Southeast Precinct, and we'll discuss that in a moment. As part of the program, Michael mentioned that we do want to make sure that our officers are prepared to ride with clinicians. So we do provide them with an extra 40 hours of crisis intervention team training. As part of our program, we would prefer, I won't say that we strictly disallow it, but we would prefer that the officers riding with the clinician have been through this training. In the early days, because so few had been through it, we cross that line a little bit every now and then. However, we're at a point now where pretty much an officer with a clinician has received that training. The need for training, because when we started, we wanted to ensure that everyone assigned to our patrol division has received this training. Now, the training consists of de-escalation training, identification of different intellectual disabilities and mental health crisis scenarios, ways to calm individuals going through those crises, and also an education about the resources that exist within Davidson County, so that if for some reason we don't have mental health co-op available, we would know where to transport an individual to get the proper help. That is not a jail cell. In order to effectively conduct the amount of training we would have to do, which ends up being over the past 4 years, we do approximately one a month, about 10 months out of the year. We created a position of training coordinator that is actually an employee of the mental health co-op. That position coordinates, plans, and facilitates all of our training, along with help from my office. And since we have began that, approximately 700 sworn members of our department have received this training. So we're closing in on, that's, I believe, a little under half of what we currently have with the Metro Police Department. Now, not all those individuals are in patrol. We have had people receive the training in patrol and then move on to other divisions. We have extended the training to all our school resource officers so that they could be better equipped to deal with mental health crisis calls within schools, and also our SWAT teams and special response teams, as they respond to a lot of mental health crisis calls. They have, every full-time member of our SRT has been through the crisis intervention team training. Michael mentioned a couple of successes that I will mention again and give a little more information on, since they are on the police side. Michael talked a lot about the outcomes on the mental health co-op side, but he did mention that one of our main goals is to divert from the criminal justice system and into the mental health care system. And so to demonstrate that we are succeeding in that, we do have a very low percentage of arrests. Michael had mentioned that in the year 2025, we were at 4%. Overall, since we started in 2021, our overall percentage is about 4.5. So we see this past year has actually been trending lower than the average over the whole program. And one thing I want to mention is most of those arrests that actually do occur are in situations where officers have limited discretion, situations where there's domestic violence situation, where state law limits what an officer can and cannot do as far as other resources. A lot of those are situations where outstanding warrants already exist, which also limits the officer's discretion. So in most situations where an officer can divert, they will, and we're seeing that in the numbers. Uses of force is low. Of course, whether you're dealing with mental health or anything, we would love those to be zero, but 2.5% in all the interactions overall since the start of the program, and that's 12,000 plus crisis interactions. The 12,000 he mentioned was overall interactions in just one calendar year. The 12,000 I mentioned, it just coincidence they're the same number, but I don't want you to get confused. We've had over 12,000 crisis interactions since 2021. And largely those uses of force are going to be soft, empty hand control. Our police department had documents anytime that we use any type of modicum of force, whether it's what we would consider to be something serious or not, whether it looks bad, we want to document that we did use some sort of physical force. And so a lot of those are going to be very low levels of force just used to control individuals in crisis. From there, I'd like to transition a little bit into some needs, because Michael and I are always brainstorming on ways we can expand the program. I don't know if I didn't mention it specifically, Michael might have, but currently we only operate Monday through Friday. We are at every precinct, and we are on the day and evening shift, but we do not cover Saturday and Sunday. So as we are coming into where the council will have a lot of discussion about budgets and needs, Michael and I have obviously been meeting a lot. We discussed, I share with him what I would like for it to look like on the police side. He tells me what he can provide on that side. And in order to do that, we need money. So it's just the nature of the beast. But so what I'd like to talk about that for a little bit, because based on our temporal analysis, when we got together last year, we worked on a plan for fiscal year 26, which is the current fiscal year, which would have actually began an expansion into weekend hours. We had some unforeseen complications during budget season last year, and we did not receive any money for expansion. That was to nobody's fault in this room. It's just one of those things that happens whenever you're trying to do something on a larger scale. So I didn't want to make it seem like I'm criticizing it here. I most certainly am not. But there were some issues that we met when we were trying to request budgets in that particular fiscal year. But our temporal analysis in that year highlighted that we are missing a lot of crisis calls on Saturdays and Sundays. There's a lot of people that say, well, what about the overnight shift? And that's another area for need, but I think that's a little bit down the road, because I'll go back to what we were talking about. Every decision is data driven, and we're going to expand to the area of next greatest need. Currently, our data shows that as Saturday and Sunday. If the time not covered by a clinician on most days that they're on duty is from about 1 a.m. to 6 a.m. So we're only talking about a 6-hour block of time where we're showing a very low level of potential crisis calls. It's less than 5% of the calls overall in the county would occur during those hours. So we currently would like to see an expansion that would start placing clinicians on Saturday and Sunday to cover the weekend hours to help that area of greatest needs. Now, I mentioned training earlier because if we, part of this budget request is going to be to house the training coordinator position, or to have an increase for the training coordinator position. And the reason that is because when we first started this program, our training coordinator was funded by the American Rescue Plan Act. And those funds ran out last year. Mental Health Co-op took on that expense through their budget, even though there was no increase last year, and led to a couple of cuts in the Partners in Care, a couple of Partners in Care positions. It actually led to us not being able to expand to the new Southeast Precinct until it had been open about a month. So we did actually contract our services for a month. But I mean, Michael did great things on his end to finagle that budget to get clinicians into that precinct as fast as he can. But I would like to make a point that we have, so that training coordinator will have to be on the books and come off of those federal grant dollars. The training is extremely important because, as I mentioned, we're currently not 7 days a week and we're currently not 24 hours a day. The training is not just so an officer will know, hey, what do I do when I have a clinician partner in the car? As I mentioned, that training provides them a lot of resources to handle those calls for service. So when an officer who has received the crisis intervention team training is out without a clinician and there's not even a clinician available because it's an hour they don't work, they still now have that knowledge of where they can divert and where they can refer these individuals to services. So even without the presence of the mental health co-op in these situations, we still have the ability and the resources to care for them better than we did prior to the existence of Partners in Care.
That's one of my favorite data points from the program since inception is during the pilot, about 5% of calls were calls that other officers were calling for the Partners in Care clinician. That has grown to almost 30% to this day, where now we're getting a lot of calls where officers are out on other calls, recognizing the signs and symptoms of mental illness and that someone needs an intervention, and call the car with the clinician over to their scene.
And to dovetail off that, and I will conclude with this. This is one of those things that I've been in police work for 20 years, and I've been involved in a lot of different things. And I can tell you that when I walk out dressed like this in the history of my career, not everyone has always been 100% supportive of the work that I do. And that, that's just the nature of the beast and when you're in law enforcement. But when we discuss Partners in Care and we discuss that the work we're doing partner with Mental Health Co-op, it's almost universally appreciated. Through the officers in our program, when we talk to members of the public, and when we talk to you guys, it's been amazing the support that you provided with us. We believe wholeheartedly in the work we're doing, and we just ask that you continue to support it the way you have, and we'll continue working as hard as we can to provide the best services for psychiatric services for Nashville. And I see hands, so we will open for questions. We're all about taking questions.
We will absolutely open it up for questions. I saw a lot of hands go up. I had just a couple of questions just to kick it off. I'm curious from the police department's perspective, knowing that you've got that increase of calls coming in, originating from police officers, what does the protocol look like for an officer when they get to that point, or when they get to that point, I should say? So, for example, an officer gets on scene, what steps do they take before they make that call?
So it's it's kind of like anything with, and sorry to answer this with my back to you, but the mic's this way. It's kind of like any call for service where you would recognize that you need some sort of specialized resource. So as Michael mentioned, our clinicians are attached to our patrol details, so the response is going to be very quick in those situations. But through a lot of the training we provide, whenever an officer recognizes that, okay, this is probably a mental health crisis situation that would be better suited if I had that resource here, it's as simple as just getting on the radio. And if that car is available and not currently dealing with another call for service involving mental health crisis, they would just ask for them to, hey, can you send me our designation at all these precincts is car 95. Well, so it's just because it was the number that was available. It has no significance. But the officers would just say, could you send the 95 car over here? And they would know that there's a potential mental health crisis situation that needs their evaluation, and they'd start right away en route.
Great. Thank you. Councilmember Allen, I think I saw your hand.
Thank you. I appreciate y'all giving us this update on this because we worked so hard to make this happen many years ago, and it's exciting to see it be so successful. Speaking of data, is there any way to quantify how much money the rest of the department is saving by not having to book people that don't have any business being booked and stuff like that? I mean, it'd be easy for us to give you more money if we could quantify how much you're saving us. And we'd love to do that.
That's a good question and something that I actually need to get my office to work on, because I think we could get you a pretty good estimate. Because one of the data points that we track on the police department side is, did probable cause exist to make an arrest? So we track if they went to jail, but also, I mentioned there's been 12,000 plus crisis interactions. Obviously, in 12,000 plus crisis interactions, not everybody is going to even have an arrestable offense. So we do track that, so we'll know how many do. So I could foresee that we could take those numbers and maybe get with the DCSO and maybe just multiply it by an average time spent, because we wouldn't know how much time they would actually spend, but we could probably ballpark that. It's a great point, and I'm embarrassed I didn't think of it, so I will totally give you credit for it whenever, if I do come up with those numbers.
Officers and ERs might be another.
Yeah. Councilmember Evans, you're recognized.
Thank you, Mr. Chair, and great to see you guys. Appreciate y'all being here. I've got two questions. So, Director Randolph, when you were talking about that 2 clinicians are assigned per precinct, are those clinicians that basically, I don't want to call them permanent because they're probably never going to be permanent at one precinct, but do they stay there pretty much the whole time? Do you shift them out to other precincts, or is the purpose to have them build like more connection in the community?
Yeah, and I'll let Anthony talk to some of this. For true culture change, we really came together, MMPD and us, to embed them at the precinct level, where that counselor shows up every day to that roll call. They know their coworkers there. They rotate officers they ride with. Sometimes that car with that officer, that precinct car, could be pulled to another precinct for extenuating circumstances where there's somebody to help. But generally, they have an assigned clinician. So 4 out of that 5 days, that same clinician will be there on A detail, which is 6 a.m. to 4 p.m., and then B detail, which is 3 p.m. to 1 a.m.
Okay, awesome. Thank you for sharing that. Thank you for the Car 95 reference too. I didn't know that. And then the other question that I had, I went through the Red Cross training and volunteered at the fairground shelter. And so when I came on Sunday, one of the things that the leader of the shelter said, hey, make sure you do not talk about people's power outages and give too much specifics, because we had a meeting early this morning where there was concerns expressed that people are going to start having some decline because of the uncertainty. And so I'm just curious, was that something that came from you guys? I wasn't sure what the source was in that context. Okay, so it was another mental health professional that was giving them that
I know the
guidance.
Red Cross has their own disaster mental health professionals as well.
Oh, okay, cool.
We've been working with them.
Okay, got it. And then on the, and kind of dovetailing into like the disaster side of things, because now, what was it, 2021 that you all were created? Okay, so 2021, and so now we've been through several disasters. Have you ever thought, and maybe this is something health could help with, on the data side, kind of segmenting data information by disaster and measuring like what the acuity kind of looks like in that time frame? Because we know that since this is a countywide experience, that there may be a spike, just based on kind of outages and things like that.
I think that's super interesting. If we can get with Paige, the epidemiologist, the health department, and I bet the time frame will have different data trends than the norm, I would assume, but I let the data speak for it. But we did a lot of helping people get to warming shelters and things of that nature,
That would be super interesting to learn, especially if we could go back and kind of getting into like, what Councilmember Allen was talking about, like with cost savings and things. I think it could tell like an even more compelling story about the value that you all bring. And so I'd be interested in that longer term.
Thank you, Councilmember Evans, Vice Chair Prep, you're recognized.
Thank you, Mr. Chair, and thank you, Director Randolph and Captain, for being here and answering these questions. I've got sort of, I would say, 4 categories of questions. The first one is for you, Captain. Separate and apart from the Partners in Care program, could you talk about the training that officers receive for dealing with folks who have intellectual and developmental disabilities? So like folks who are living with autism who are nonverbal, or folks who are living with Alzheimer's and start sundowning, which is a clinical term for whenever folks living with autism or living with Alzheimer's, they're fine during the day, but then as the sun goes down, they start reverting and exhibiting symptoms. Could you talk about the specific training that officers receive both through this program and separately about how they interact with folks with intellectual and developmental disabilities?
Yes, and I'll answer that question with something very specific, because my knowledge of the mental health spectrum is obviously not as great as my colleague, Mr. Randolph, but I am overseeing a lot of the CIT trainings and I see what they go through. And so they're provided a lot of information about ways to recognize what could potentially be an intellectual disability, such as one of the ones you mentioned. And I say recognize, not diagnose, because we don't do that. But if you can pick up those context clues, then you can transition into what might be a better way to actually interact with that individual. And the specific story that I was going to say to answer that with is, I know that we do a portion of our training where we show some actual body-worn camera footage of interactions. And there's one thing I always point out, because one of the things that they talk about is certain intellectual disabilities, it takes a while for certain things to register. So if I give you some direction or ask you a question, it might take you a while to process that. And as police officers, sometimes we're historically trained to be in control of a situation and we want to get an outcome pretty quick. So in a normal situation with somebody without a disability, if I'm like, hey, I need you to step over here, and they don't do it, we're going to want to facilitate that as quickly as we can. With this training and with the understanding and recognizing certain things, officers know that if they've recognized that they can actually slow themselves down a little bit, take an extra moment. And the situation that we show in one of our camera footage is an officer gave instruction to an individual who said that they weren't going to do it. The officer was very patient. The officer actually never asked the question again. And the individual then said, oh, you want me to step over here so everybody will feel safe? And then he does it. And so I always make a point to point that out to officers, because earlier in the week we have talked about that cognitive delay of when someone asks a question. And so it could have been bad if an officer is like, well, I told you to move. I need you to move for safety. But this officer recognized in that situation, okay, well, let's stay patient. And you can see it on this thing. He never even re-asked the question. It's just that all of a sudden it sort of clicked with that individual, and then they moved over and followed the direction. So like I said, I know that's a very oversimplified answer to your question, but it's a real world example of the way that the training that we provide can help those interactions.
I can piggyback on that too. Our training coordinator is embedded at the police academy, and Amy, they get the building blocks of some of this. So they'll get an introduction into autism at the police academy during their time there. And then the CIT training builds on that. There's blocks of training in CIT and at the academy. And the CIT training will have guest speakers come out from the Department of Aging, which now houses intellectual disabilities with the State Department of Tennessee. They'll send their trainer out to train the officers during the CIT training as well.
Perfect. Thank you for that. And I'll simply add, just from my own perspective as a person who's both a little hard of hearing and also diagnosed with ADHD, that sometimes it takes me a moment sometimes to register what folks are saying to me. So I can appreciate that. And then I also appreciate the fact that this is geared towards non-carceral solutions for mental health, but understanding that we do also have some carceral resources that are available to folks. Could you talk about how the Partners in Care program interacts with the behavioral care center that's run through the sheriff's office?
I think Actually, I'll let Michael in just a second take over on that, but I think they interact more with what they have as a jail team over there that's actually operates a little independent of BCC, correct?
Sure. It's changed a little bit as Vital Core has come in and taken over that jail contract. BCC still run with Mental Health Cooperative. So we're able to communicate the counselors with the jail team, with Vital Care, and with the BCC jail team with MHC to identify individuals, even if they are arrested, that we get them assessed and get the resources in jail if they are being booked.
We still do stress in our training the importance of diversion on the front end because those resources do exist in jail, but I don't want officers to go, oh, I can arrest them and still get help. So we stress that it's better to do it on the front end. And because we have had in the past situations where the communication wasn't as, was not shored up the way that I would like it, and someone ended up being discharged prior to a mental health evaluation. So in order to ensure that things like that don't fall through the cracks, it's always better for us to handle it on a non-jail response.
Thank you. And then this question's a little more complicated, so feel free to say that you don't have this information at this time. But I'm curious because one of the things that I think we benefit from is having the Middle Tennessee Mental Health Institute located here in Nashville. Do you know what the current capacity is at MTMHI or what the bed availability is?
It's complicated. They have about, I want to say 187 beds. I want to say that they operate on a wait list. Usually it takes 2 to 3 days to get through the wait list. At that point, their admissions department will do a telehealth assessment either at the crisis treatment facility or an emergency room. That physician would then admit them to the MTMHI, and then they would get transported, or at that point, they would get resources and go home during that second evaluation.
Okay, perfect. And then my last question is, with the Partners in Care program, do you all ever do involuntary committals to MTMHI or other resources here? And what is the process for doing those involuntary committals?
Sure. Before you start, I want to, because I'm going to let him speak to the specifics of your question, but I do want to make a point as we talk about diversion. Not only do we look at diversion away from the criminal justice system, but one of the data points that he mentioned was that 50% of those crisis calls, they try to solve at home or at scene. So as we look into, we don't want to have to work to legally restrict somebody's freedom on a criminal side. They actually do everything that they can to prevent legally restricting someone's freedom on the mental health side via those 6404 certificate of needs that you discussed. I wanted to throw that point out there before I turned it over him to all the inner workings of how that works. But
yeah, so the mental health crisis system is pretty complicated. I'm going to try to break it down for everybody. So I have worked at Mental Health Cooperative for 17 years. I've been a mobile crisis counselor in some way, in shape or form that whole time. All of our clinicians and partners in care can do everything a mobile crisis counselor in Davidson County can do. We do full crisis assessments that could lead to a 6404 if there are no available alternatives and that person is in imminent danger to themselves or others. But we also have the Crisis Treatment Center in Metro Center, which has diversion beds. We have our Adult Crisis Stabilization Unit in Metro Center that has diversion beds. And we have our Kids Crisis Stabilization Unit in Metro Center that just opened in December 1st, I believe. With the whole goal is hospitalization can be traumatic. And all of our counselors are trained to answer these crisis calls in the most trauma-informed possible and minimize that trauma as much as we can. You don't want to hospitalize someone. It's sometimes it is necessary, but it's just such a hard process on the consumer and administratively. So we'll sign a first set of 6404 papers. Also on these crisis calls, a clinician does not make a decision in a silo. Every clinician consults on every crisis call they go on in Partners in Care with a senior, with a supervisor or myself. Even if I go on a crisis call myself, I consult with another supervisor as an added level of clinical quality control on the calls we're going on. So then if we initiate that first 6404, they'll either go to our crisis treatment center and Metro Center or to an emergency room because usually there's a medical clearance requested. We will start the patient bed matching system, make the referral to MTMHI, and begin that process. That process usually takes 2 to 3 days to get them an evaluation from MTMHI to get them admitted or sent home. It can be a very complicated process. The whole program is designed to to address frustrations, frankly, with the public's interaction with the mental health system, with officers' interactions with the mental health system, and crisis counselors. We're trying to eliminate all the barriers that we can, streamline this whole process to make it faster. We don't ask, we'll talk to anybody that the police department wants us to talk to. They don't have to be suicidal or homicidal or psychotic. We just want to help people and design a program that helps the most people possible with eliminating as many barriers as we can.
Along those lines, I'd like to throw some kudos to our partners with the Metro Fire Department as well, because as we are trying to streamline those avenues to care, they do a fantastic job of helping us out with certain transports. If someone does have to go to an emergency department or things like that, they've helped out with ambulance transports. They can do some of those things through the REACH program. But the fire department was a big supporter of us and partner in all of this when we first started. And in our CIT training, they actually sent a decent amount of personnel through our early days of crisis intervention team training, just so that they could also learn what the program does and how to better interact and how to create those avenues of care. So, when we were talking about it, the reason we call it Partners in Care is because it's not my program, it's not his program. There's a lot of us involved that are trying to make this work for the betterment of the mental health of the public.
Great questions. I like specific questions.
Thank you all so much. And so Director Randolph and Captain, thank you all for your commitment to this program and for advocating for more resources for it, because I think this is something that we should expand and fully fund. So thank you. And with that, Mr. Chair, no further questions.
Thank you, Vice Chair Prep T. Councilmember Weiner, you're recognized.
Thank you. This is going to be pertinent to the hell that we just lived through. And I think about some of my constituents who have special needs and didn't register what was happening, and we had to have them transported through, in 4 instances, Adult Protective Services. Having said that, NES has a program that allows for critical care identification for an elevated level of service and to get care and service first, right? Is that something that is appropriate and possible to extend within the Partners in Care program to urge these folks to identify with NES that they need that elevated level of engagement?
That's a good question.
In other words, let's get them turned on quicker?
So is your question to reach out to NES and have them prioritize individuals in mental health? I think it would be great if that were possible, but I don't know if this is the avenue for it. And I know there's a lot of things going with that being an agency that we don't. There's a lot of political stuff I know happening right now in the news with NES, so I'm going to withhold certain comments about that. I think it's an interesting idea. I don't know if we're the proper avenue for it. And
well, like any kind of PHI or, any kind of health issue, it would have to be self-driven by the patient and the patient's physician. And so it might be something that we want to explore. Just in terms of notification to these people that when you're engaged with them, oh, by the way, in the event of a tornado or whatever, this is something that's available to you, but it has to be driven, because certainly from a PHI standpoint, we can't go, oh, by the way, Joe Smith. But a case in point, I had someone who decided that it was appropriate to sit in her car with her dog, turning the heat on and off in the car all night. And she was literally, her car was adjacent to an active power line that was down. So just things that we need to think about.
Yeah, absolutely. Yes, ma'am. Those are very interesting questions and look for solutions. And what I can say on that, and it's not really an answer to that question, is that, and Michael touched on it a little bit, I think he just kind of briefly mentioned it, is during this crisis, our Partners in Care cars and some other resources at our department, when they know of individuals like that, have been very intentional about reaching out to them specifically to see what needs they have. When I said Michael touched on it, there have been a lot of transports to warming shelters. Our central clinician does a lot of work with the unhoused community. And so they were doing a lot of checks in on camps and things like that. But I do know that officers and clinicians, when they know of individuals in their areas who are similar to have similar needs to what you're describing, that, we might not be able to get the ball rolling any faster on the electrical service, but they're doing what they can in outreach wise to try to get them cared for so that at least they're safe.
As long as they're notified of that opportunity, I think that would be great.
We will work with any resource or agency that we can to get people the best
Great.
care that we can, best help.
Perfect, thank you. Chair, I'm going to add that to the list of 50 questions I already sent you.
Yes, ma'am. Yeah, and Captain Brooks and Michael, just for y'all's reference, we have a special called meeting on Tuesday of next week to discuss how we can improve emergency communications moving forward. This will definitely be an item that I can see on that checklist, so that we can be better prepared to serve our folks. Thanks, Councilmember. Councilmember Nash, you're recognized.
Thank you, Mr. Chairman. It's been a while. Been retired 14 years now, but it seems to me somewhere the Emergency Communications Division also has a list of people who can register with special needs. Do you know if that program's still active and how people can apply?
I'm not the most versed on it. I think it's called Smart 911. I think some of our trainers come in and do train on that. I have not personally used it, so I can't speak of it, but I do believe we give that resource out to families.
Well, this is what I love about the partnership, because I was going to say I'm unaware, and then he jumps in and answers it. So
Maybe we ought to become more aware. Get the word out. It's been a while. Thank you, brother.
Thank you, Councilmember Nash. Any other questions? I do want to close us out by highlighting, we got a couple good takeaways. I think that just to wrap that up, Councilmember Allen's question around overall savings around potential bookings, that would be very interesting, especially as we're coming up on budget season. And Councilmember Evans' inquiry regarding the data points from the disaster timeframe, very, very good and not to put a time on it, but if that could be a part of our discussion of how we improve communications moving forward, that would be really good. I want to point out, too, another data point, or lack thereof data point, that we're not talking about, and that is the data that never gets seen because it never happens, because y'all are where you are. The amount of lives saved on an annual basis is just insurmountable. The amount of just stress that you take off of people because you're there, it's a tremendous service. It's something that I talk about a lot with colleagues in other cities, that we have this here, and this should be something that you should be following too. So thank y'all very much for your work, and thank you for coming to our committee today. We really appreciate you.
thank you very much. We appreciate you having us.
Thank you. Anything else from anybody? We're adjourned. Hey, Michael, appreciate you. That was, I will absolutely.